Until at least the 1st of July 2011, you're required to comply with the HQCC standards, and we're going to ask you to report one more time, but that will be over a 12-month period. So why standards? Basically, as health service providers, your legal obligation is to have processes to improve the way you work, and the standards guide you towards satisfying that obligation, as well as looking at your ability to monitor outcomes. So what's changed? The review is complete, and what have we done? We've simplified the format and removed a lot of the duplicate content. We've replaced 98 principles of process, outcome and improvement with 91 criteria. The criteria meaning that what we want you to do to comply with the standard. And we replaced 135 compliance mechanisms with 34 measures. We had originally intended to roll out the reporting process to all practitioners in private practice, but that's proven to be a task quite beyond us. So we've issued a statement that although the HQCC currently requires only hospitals and day hospitals to report against the standards, all Queensland healthcare providers have a statutory duty to Section 20 of the HQCC Act. And one of the most important criteria addresses commitment at the executive and leadership levels to improving the quality of the health service and identifying opportunities to implement improvements, and that the leaders share with all the staff their concerns about safety and quality issues and the improvements that they have planned. As Cheryl alluded to, we've tried to raise the bar and tighten them all up a little. The focus on providers' duty standard has been increased. This is our foundational standard related to Section 20 of the Act, and it now focuses on governance, risk management, clinical incidents management, standards compliance, executive and clinical leadership, and improving the safety and quality of care. It's actually very similar to the national standard they have for governance. Credentialing has got major changes here. We worked closely with Queensland Health on this one, and it was difficult to generalise the terminology to satisfy the processes undertaken by both public and private facilities. The guideline remains the national guideline developed by the former Council for Safety and Quality in Healthcare, and it remains the only guideline available in Australia. The scope's been extended to include eventually all health practitioners, but initially medical and dental, particularly the dental practitioners working in the public sector. We understand that Queensland Health currently has a project to develop credentialing and scope of practice processes for their dentists. We've also developed measures for this standard, which we previously didn't have. And this standard is probably the most prescriptive of all of our standards, but it was essential to do it this way to cover all aspects of the process. Complaints management still follows the former Council's guideline, but we've amended the criteria to better reflect all aspects of the Better Practice guidelines, and also to align with the Australian Charter of Healthcare Rights that was developed by the National Commission in 2008. The review of hospital-related deaths has had moderate changes. The amendments incorporate changes to the Coroners Act 2003 and the new reportable deaths category of healthcare-related death and its definition. All deaths in hospital must undergo at least a Level 1 review. Even if the death is reportable, a Level 1 review must be completed. We've expanded the timeframe for completion of a Level 1 review to 2 weeks. A Level 2 review is warranted if a concern is raised or a complaint is made concerning the care of the deceased, or if a root cause analysis is commissioned, or if multiple clinical units were involved in the care. We've made moderate changes to this standard. The scope of the standard now states all patients recovering from type 1 AMI and ready to be discharged or transferred to ongoing care. Ongoing care meaning transfer to primary care, nursing home, convalescence or usual home of residence, not transfer to another hospital for acute care. We understand there are concerns about this amongst providers in relationship to their reporting, and that if a patient refuses to accept referrals for lifestyle advice and cardiac rehab, among others, they'll be non-compliant with the standard. If at any time we decide to follow up on any provider's non-compliance, we'd like to see that the patient's refusal to accept the referrals is documented in the medical record. In that case, we can be satisfied that the provider's attempted to comply, but the patient, for reasons of his or her own, has refused. Major changes to VTE, as you would be aware, the scope's been extended to include medical patients. This is something that's been recommended by many clinicians since the implementation of the standard in 2007, and it was also a recommendation with an expert reference group and consultant. Our criteria for this standard now focus on risk assessment, improving the communication between clinician and patient, and educating the patient on how to recognise the symptoms of a DVT. Of course, we do understand the main problem with the risk assessment is lack of documentation and the labour-intensive auditing required to report this to the HQCC. The 3 Cs. Major changes here include the scope expanded to include invasive procedures such as radiology, oral surgery, radiation therapy, nuclear imaging, and this is in line now with the guideline from the World Health Organization. Another aspect of this standard focuses fairly closely on correct patient identification and the important introduction of the surgical safety checklist. This is a very important development. It also includes confirmation on this checklist that antibiotic prophylaxis and or VTE prophylaxis has been given to the patient. Hand hygiene, the more moderate changes, the scope's been expanded to include patients and visitors. There's now a focus on cultural change management program involving all parties as developed by the Hand Hygiene Australia. And finally, surgical antibiotic prophylaxis. The focus here is on, once again, education of the patient as well as the staff. Patients need to be educated on recognising the symptoms of a surgical site infection. Oh, and I'm sure you're all aware that there's a new version of the antibiotic therapeutic guidelines that were published about a week after the standards went live. So it's now version 14 that you should be looking at. So the future amendments to the standards, they'll be minor only in view of our uncertain future, such as corrections to spelling, grammar or punctuation, clarifying words, phrases, or even additions purely for clarification. There may be additions to the glossary and, of course, updates to any reference guidelines. Providers will be informed by email of the amendments and they'll be effective from the date you are informed. And the web page will also note an update has been made.